Hello, everyone, and welcome back to our video series. This time, this is the second video about the cardiac cycle. And this time, we are diving deep into the concept of cardiac cycle with more definitions and more in-depth explanation of the cycle itself, and within still the framework of what, when, how, and where, and the one that we are usually using. So I'm Dr. Sara Ahmed, and I have introduced myself in the past. I would like people to follow my channel, because I'm planning to produce this video series that is intended to help students for the USMLE Step 3. But I think any medical student and any young physician can benefit from these concepts that I'm planning to kind of present and explain in a simple and easy to understand manner. This cardiac cycle, understanding it is fundamental, I think, and it's really the basis for understanding a lot of cardiac conditions and the clinical applications of different therapeutics and interventions and so on. So grasping these complex conditions of cardiovascular diseases like heart failure, atrial fibrillation, and arrhythmias, or like, as I said, heart atrial fibrillation, is crucial. And as internists, we rely on this kind of knowledge, basic knowledge, all the time. So this time, let's break it down using our trusty what, why, how, when, and where framework. Okay? And we'll start talking about the cardiac cycle in phases. We'll start with the first one, which is atrial systole. So what is it? Atrial systole is the contraction of the atria. And actually, the contraction of the atria happens at the end of the filling process of the ventricles. As you know, atria receive blood from the body or from the lungs, and these processes happen at the same time. People need to remember that. It happens at the same time, meaning both sides of the heart receive blood and both sides of the heart eject blood simultaneously. So it's not two different sequential events. No, they happen at the same time. And these atria receive blood, and most of the blood moves from the atrium into the ventricle passively. It just flows in. And atrial systole comes at the end of the filling process of the ventricle, or the emptying process of the atrium, to kind of squeeze the rest of the blood into the ventricle. So it's not as powerful as the ventricular ejection, but it's necessary to happen. Think of it as a top up between or before the ventricles take over. We are still talking about the process before the ventricles contraction, relaxation, and all these things happen. And remember, the ventricles are the major and the main players here. They are the actual pump. Okay, so how does the atrial contraction happen? Usually there is an electrical signal originating this or triggering this contraction. It originates in the SA node, and it triggers what we call atrial depolarization, which leads to the contraction. Usually, depolarization is the trigger for contraction. Repolarization corresponds to relaxation. Okay. Last time when we talked about the cardiac cycle, we didn't focus on the electrical component of it. We mostly talked about the mechanical components. Okay, the mechanical components, the pressure synthesis by the contractions, the flow of blood, the opening of valves. All these are mechanical events. That's what we focused on last time. This time, we'll try to link this mechanical activity to its trigger, which is the electrical component of the cardiac cycle. Okay? So, this atrial systole, it happens during ventricular diastole. Okay? And since what happens to the ventricle is actually more powerful and more important, I would say, usually when we say cardiac diastole, we mean ventricular diastole. Okay, despite the fact that the atria, which are basically the reception points for blood, the atria has their own systole and diastole, mini cycle. But the more powerful one, the more pronounced one, the one that we feel is the ventricular cycle, systole and diastole. Okay, so this atrial systole, which is beginning the cycle for us, happens during the diastolic phase where the heart, the ventricle is receiving blood. It's relaxing. Okay. And as I said, the two atria at the same time, and later the two ventricles at the same time. These things happen to them at the same time. Okay. Then we go to the next stage, which is called isovolumetric ventricular contraction. After the atria contract, ejecting or squeezing the last drop of blood out of them, all the valves, or the valve between the atrium and the ventricle, closes. That's the tricuspid valve in the right side and the mitral valve in the left side. Okay? They close because the opening and the closure of the valves depends on the pressure differential between the two chambers. At the beginning of the ventricular diastole, the relaxation and filling phase of this ventricle, the pressure in the atrium, which is full of blood at that time, is more. That's why both valves, tricuspid and mitral, are open, and blood starts flowing in, and it ended by the squeeze, the final squeeze of the atrium of blood into the ventricle by atrial systole. When the atria loses blood, they lose pressure, and the pressure in the ventricle is getting higher and higher until it closes the valve. Now we are at a state where all the valves are closed, and each ventricle has two valves. Yeah, one between it and the atrium, and the other is between it and the great artery linked to it, which is the pulmonary artery for the right side and the aorta in the left side. Okay, all these valves are closed, and at the same time the ventricle is starting to contract, and contraction builds pressure. So we are building pressure, but nothing is moving, nothing is flowing. The volume is static. The volume is static. Okay, that's why it's called isovolumetric, meaning the same volume contraction. This is followed by another state. where now we have the opening, we have enough pressure to open the pulmonic and aortic valves. And when this happens, the pressure pushes blood out. Now we have flow out of the ventricle, blood flowing out of the ventricle. Okay? This is the result of building enough pressure in the ventricles necessary to overcome the pressure in the aorta and the pulmonic arteries, leading to the opening of the valves. Okay, how does this contractile function or this contraction happens? Again, just like the atrial systole, atrial depolarization leads to that systole. Here, ventricular depolarization, which is equivalent or corresponding to the QRS complex in the EKG. The electrical activity that's corresponding to the ventricular contraction is the QRS complex. Okay? Okay. So, this is the phase that leads to the next phase, which is the ventricular ejection. And ventricular ejection happens when forceful movement of the blood out of the ventricles into the great arteries happens. Okay, and this is where the money is. This is the main function or the main event that we are waiting for. Blood moving out of the heart, going to where it needs to be. Okay? This is the main pumping action of the heart, delivering oxygenated blood to the body and deoxygenated blood to the lungs. And as I said, these happen parallel to each other. At the same time, both sides eject blood and both sides receive blood and both sides do everything parallel to each other. Okay? The high ventricular pressure opens the aortic and the pulmonic valves, and this leads to the flow from the high pressure area to the low pressure area, which is the in this case the aorta and the pulmonary artery. Okay. So what happens after this? After we ejected the blood that we need to eject, we come to a state which we call isoventricular relaxation, isovolumetric ventricular relaxation. The earlier isovolumetric ventricular contraction, that's a phase that was intended to build up pressure. We want to build up pressure to overcome the pressure of the aorta so that we have a pressure difference ready or enough to open the aortic valve and here to open the pulmonary valve in the right side. Now, these valves opened, we ejected the blood. Now we enter into this phase that's called isovolumetric ventricular relaxation, where we have the same situation with all valves closed, but the heart muscle or the ventricular muscle is relaxing, dropping the pressure. Okay? There is some volume inside it. We call it end diastolic volume. Okay? There is volume inside, but the pressure is dropping because the heart muscle is relaxing. The builder of the pressure is the heart muscle contraction. Okay? The ventricles relax and all valves are closed again. Volume remains constant. The volume is not changing. There is no flow of blood. This drops the blood pressure in the ventricles enough to become below the atrium. Atrium is a low pressure chamber, by the way. But we have to drop it in the ventricles low enough for the valve between the atrium and the ventricle to open. Okay? And this relaxation phase corresponds to the ventricular repolarization, which is the T wave in the QRS. The T wave corresponds to ventricular repolarization, which is the relaxation phase of the ventricles. Okay. Then restarting the process of ventricular filling, which starts by the passive ventricular filling. Just the act of opening the valve, the tricuspid in the right, the mitral in the left, will allow blood to go in the ventricle passively. Okay? From the atria to the ventricles. And at the end of this passive filling comes an active process of the atria contracting to squeeze the last drop of blood into the ventricles to complete the process of ventricular filling. Okay? The blood flowing from the atria to the ventricles happens along the pressure differential. The pressure in the atria is higher at this level than the ventricles. Okay. Then this is the cycle. So we started with the atrial systole, which is the final act of pushing the blood into the atria and by contracting the atrium, and we went through the cycle. Now the cycle is over. These are the events that happen during the mechanical events that happen during the cardiac cycle. Each mechanical event has a corresponding electrical event, which is shown by the EKG. We have a couple of waves and intervals and all these terms that happen, and each complex or wave corresponds to a specific phase in the cardiac cycle. We mentioned the QRS complex corresponds to the ventricular contraction, which starts as isovolumetric phase and goes to the ejection phase, this contraction process. This corresponds to the QRS complex. Okay, when the ventricles start to relax, this corresponds to ventricular repolarization, which is the T wave in the QRS complex. Okay, in between these complexes or waves, we have intervals, and we have other terms that we use to define how to read or interpret the QRS. We will make a video about what all these mean and what does it mean in clinical applications. So we'll talk about the EKG and try to understand this concept, which is very important. Okay. As part of completing the talking about the cardiac cycle, I thought it's necessary to touch upon some definitions that you will kind of come across when you are dealing with cardiac conditions in terms of therapeutics, interventions, or even understanding pathological conditions affecting the heart. Okay, so let's go and try to understand these definitions. One of the important definitions is a term called cardiac contractility. What that means is the force and velocity of contraction of the heart muscle. Okay, basically how strong it can contract and how quick it can respond to stimuli. This is contractility. And this contractility is affected by a couple of factors. Okay, one of them is called preload. We'll explain what that is. The afterload, substrate availability. And let me explain what that means. The substrates for the heart muscle to work or to function, the most important are oxygen and glucose. Okay? the vehicle through which this is delivered is through the blood flow to the heart muscle, which is delivered, or which is the coronary arteries. The coronary arteries are the arteries responsible of delivering blood to the heart muscle, nourishing the heart muscle. So substrate availability basically is talking about how good your coronary arteries are in delivering these essential nutrients. Okay? If this delivery system or process is adequate, your heart can overcome whatever it needs to do or to overcome and function properly without any dysfunction. But if somebody has coronary artery disease and his or her coronaries are narrowed by atherosclerosis or other pathologies, then the blood flow is impaired, and any extra demand on the heart will not be tolerated and it cannot function. And if you continue to push through, then you will start having chest pain, pain due to ischemia, which is low oxygen state. Okay? So the substrate availability is one of the factors that impact how strong, okay, and how rapid the heart can contract. Okay? Ischemia causes cardiac dysfunction this way by limiting the amount of substrate available. The other things that affect the contractility is the heart rate itself and the amount of viable myocardium. And this is another thing related to ischemia, or can be related to ischemia, which is when people have heart attacks or any other insult to the heart muscle, and as a result of these insults, they lose myocardial cells, they will over time lose viable myocardium. And for proper function, you need viable myocardium. You need a healthy living cell rather than scar tissue, because scar tissue is non-functioning. Okay, it's just filling space, but it doesn't function. It doesn't contract. It doesn't relax. It doesn't do anything. It's just sitting there. Okay, like a piece of rubber or a piece of anything. Viable, the amount of viable cells that remain or are not affected by different pathologies. One of them is necrosis or myocardial infarction, can determine how strong or how good the cardiac contractility is. So in short, the factors that impact the cardiac contractility, meaning how good and strong the heart can contract, are preload, afterload, substrate availability, heart rate, and myocardium viability, or the amount of viable myocardium. Okay, now let's go to the other terms. What is preload, which is mentioned here? Preload is the loading condition of the heart at the end of diastole. This is the relaxation phase of the ventricle before contraction. So at the end of the filling of the ventricle, that's end diastole. Okay, this is called preload. When you fill the ventricle with blood, it enlarges or it elongates, or you are stretching the heart muscle. Okay, you are stretching the heart muscle, you are filling it with blood in a relaxed state. This end diastolic volume and pressure, by the way, end diastolic volume is called preload. Okay, it reflects the degree of end diastolic fiber stretch and is influenced by the end diastolic volume and ventricular diastolic pressure. Let's imagine that this is a phase after the tricuspid valve and the mitral valve are closed. The ventricle is full of volume, they're filled with the volume, and that's called the end diastolic volume. But there is also pressure. And this pressure and volume are actually stretching the ventricle, stretching the heart muscle. This is called the preload. And the way it impacts the contractility is the more you stretch the heart muscle, the stronger it contracts. Just imagine you have something called, you have, for example, an elastic band. Okay? The more you stretch it, the stronger it recoils back and hit you. It's the same here. The preload is this force that you exert on the cardiac muscle, is stretching it, okay, more and more. And the more you stretch up to a limit, of course, there is a limit to this, you can't exceed it, up to a limit, the more you stretch, the stronger the contraction is, the following contraction. Okay, so this is the preload. Then we come to the afterload. Okay, the afterload. The afterload is the force resisting myocardial contraction at the start of systole. Okay, which is the contraction phase. It's determined by the LV chamber pressure, radius, and wall thickness when the aortic valve opens. Now we are dealing with the releasing pressure or the pressure of contraction. Okay, what kind of forces are we contracting against? Okay, and by the way, this afterload or the amount of contraction or the force of contraction here can impact the systemic blood pressure. Systemic systolic blood pressure, because this is at the time of contraction. Okay, if it's very strong with very high resistance, it will go up. That's why people with hardening or hardened arteries due to arterial sclerosis, which is hardening of the arteries, they have more afterload. That's why they have very high systolic pressure with little impact on the diastolic pressure. Why? Because of this high afterload. Okay? And that's basically the meaning of afterload. Now we have another term which is called the Frank-Starling principle, which actually explains the effect of the preload on the contractility. That's basically what it is. As I said, just remember, an elastic band, the more you stretch it, the stronger it recoils and hits you. The heart muscle, the more you stretch it with an increased end diastolic volume and pressure, which is the preload, the more it contracts and it gets more blood and becomes, the contractility increases. Okay, the Frank-Starling principle explains that. It describes the relationship between preload and cardiac performance. Okay, stating that systolic contractile performance, which can be checked. How do you measure it? How do you measure the contractility or the cardiac performance or the ability of the heart or the strength of the contraction? In clinical settings, you check it by something called, or by the cardiac output or the stroke volume. But we have another measure for it, which is the ejection fraction. This is a percentage of the ejected blood with one contraction. Okay, the percentage of end diastolic volume ejected with each contraction. Let's imagine at the end of diastole, I have a volume of 100 mLs of blood in the left ventricle. Let's imagine. Okay? And when the contraction or the ventricular ejection happens, I ejected 55 mLs of that, or the heart ejected, or the left ventricle ejected 55 mLs out of it, and 45 remain back. This is the ejection fraction. It's the percentage of what was ejected compared with what was there at the end of diastole. Okay? We express it in terms of percentage. So now this is 55 mLs out of the 100 mLs is 55%, basically. So the ability or the systolic performance of this heart or this left ventricle is 55% ejection fraction. It's able to eject 55% of the content at the end of diastole. Okay, so these terms are very important and clinically very significant and very important to understand. We can actually calculate the ejection fraction non-invasively using echocardiogram, nuclear imaging, MRIs, and invasively through the cardiac catheterization. Okay, there is a relationship between force frequency relationship. The frequency, or this is a phenomena where increased stimulation frequency leads to stronger contractions in the normal cardiac muscle. In some heart failure cases, this relationship may become negative, resulting in decreased contractility with increased heart rate. So it's basically the heart rate or the electrical stimulation, the frequency of electrical stimulation. The more it is, the more contractility you have in a heart, in a healthy heart. Will have more contractility with more heart rate. But in a diseased heart failure situation, this might be detrimental when you have tachycardia in somebody with heart failure. It's not a good indicator. So this relationship is disrupted. Okay? We mentioned earlier that the contractility or the force of contraction is impacted by the heart rate, and everything is to a limit. And we were talking about the healthy heart. But in a diseased heart, in the heart failure situations, this could be detrimental or inverse or reversed, this relationship. Okay. The stroke volume is basically the volume of blood pumped out of the left ventricle with each heartbeat, reflecting the heart's pumping of efficiency. It's similar to ejection fraction, but we call it a stroke volume because the ejection fraction is expressed in terms of percentage. This is expressed in terms of volume, mLs, and or so on. So milliliters per pump or per beat. Okay? Okay. There is another very important term that people need to understand. It's called the cardiac reserve. The cardiac reserve is the heart's ability to increase performance above resting levels in response to stress. And stress here is not to be understood as a negative event. Stress is anything that will lead to increased cardiac activity or demands increased work. For example, exercise, running, biking, swimming, whatever it is a form of stress. Okay, it's a form of stress. So the ability of the heart to increase its performance to meet the increased demands by the stress is the heart reserve or the cardiac reserve. And just expand further about this, the more you condition your body and you condition your heart, and you have a more efficient heart, you will have more cardiac reserve. You are able to do more than the regular person who is a couch potato, basically. So conditioning and fitness improves cardiac reserve. Okay? And cardiac reserve is impaired in some disease conditions like heart failure. People can do well while they are resting and not doing anything more than just the daily activities that are not very demanding. But whenever they are exposed to any stress of any form, psychological or physical, then they plummet. They can't cope with it. Why? Because they don't have reserve. They don't have any heart reserve. They are barely making it by what they have. Okay? So cardiac reserve is an important term and an important concept to be understood. There is another term that's related to conditioning and fitness as well. That's called oxygen extraction. Basically, when you are stressed, you need more nutrients to be delivered to different parts of your body. The muscles, the heart itself, all kinds of organs need more oxygen, more nutrients. So the factors that can impact your ability to face these demands is the heart performance in terms of cardiac output, which is stroke volume and heart rate. Okay, and then the state of your vascular system and the ability of the tissues, the different tissues, to extract nutrients. The more they are able to take out of the blood, the better they can actually withstand this stress or cope with it or deal with it. Okay? So this oxygen extraction, we can actually measure it by looking at the oxygenation of the arterial blood when it leaves the heart after it's fully oxygenated, and the the venous blood, we call it mixed venous, the mixed venous blood. When we look at the difference between the two in terms of oxygen content, we can guess the ability of the tissues to extract nutrients. We call it oxygen extraction or oxygen extracting ability. Okay, the difference in oxygen content between arterial blood and mixed venous blood, which can increase during higher demand, aiding in the compensation for reduced blood flow in heart failure. This is one of the adaptive mechanisms that the body resorts to in cases of inability of the heart to meet the demands. Instead of we increase the blood flow, we increase the ability of the tissues to take out oxygen. Okay? So I thought these terms and these concepts or definitions needed to be mentioned and explained, because you will find them or come across them repeatedly, okay, when you are studying diseases of the cardiovascular system. Okay? And they kind of provide a foundational understanding of the factors influencing cardiac function and performance during the cardiac cycle. So they are related to the concept of the cardiac cycle. This is a very nice, beautiful image about the Frank-Starling principle, which is showing the stretching of the ventricle, which can impact its performance or its ability to contract The more stretching, the more contractility, but this, as I said, to a limit, because when it starts to lose its elasticity, then we are entering into a diseased state of the heart dilated and not being able to contract. Remember, mastering these foundational concepts, the cardiac cycle and its related phenomena, is key to understanding more complex cardiovascular pathologies. In the future videos, we will explore how these principles apply to conditions like heart failure, atrial fibrillation, and other arrhythmias, valvular heart disease, so on. I would like to thank you for watching this video, and don't forget to subscribe for the channel so that more of these medical videos can be you can find, and you will support me actually and encourage me to do more of this. I'm planning to continue presenting these concepts, and I will transition to disease states that we can discuss. And I started by explaining this cardiac cycle, and I'm planning to talk about atrial fibrillation, talk about heart failure, a video about the cardiac electrical activity, the conduction system, the SA node, and the different arrhythmias that can be related, and how to read an EKG. All these are in the future, and I would appreciate it very much if people can support my channel and support these videos so that we can do more of it. Appreciate it, and thank you very much, and see you in the next video. And till then, stay healthy and study hard.